All right. Welcome, everyone, to a California Thoracic Society Friday evening educational webinar. Thank you all for sharing part of your Friday evening with us, especially during this extreme heat wave that we're all living through. Tonight's presentation is titled Critical Care Management of Asthma. And tonight's presentation will also feature a live Q&A following the presentation. If you'd like to ask questions, please use the Q&A functionality at the bottom of your Zoom screen, or sometimes at the top. It's the little speaker bubble icon. If you're having problems finding that, you're welcome to submit a question via the chat, and we'll be sure to get that question to Dr. Zeki at the end of the presentation. And just to remind everyone, we will be doing the live Q&A at the end of the presentation. So you're welcome to submit your questions. We will not lose them or miss them. We will just address them at the end. And that said, it is my pleasure to introduce Dr. Amir Zeki, the Professor of Medicine, Division of Pulmonary, Critical Care, and Sleep Medicine at UC Davis School of Medicine. Dr. Zeki is a physician scientist with clinical and research expertise in chronic obstructive airways diseases, including severe asthma and chronic obstructive pulmonary disease, COPD, and the more recent asthma COPD overlap, ACO. His expertise spans pulmonary critical care medicine, clinical and translational research, mouse models of asthma, molecular biology techniques, metabolomics, lipidomics, airway smooth muscle, and advanced lung epithelial cell culture systems, and randomized clinical trials. This evening's educational webinar was developed by the California Thoracic Society in collaboration with Electromed, the maker of SmartVest. We want to give a big thank you to Electromed for supporting this educational event and making it happen. Without further ado, I present Dr. Zeki.
Thank you, Jason, very much. And thanks to everyone who is participating and for the sponsor and the invitation. I just realized that one thing I forgot to include is my disclosure slide. That's an important slide to include, so I'll go ahead and say that in a second. But I know the California Thoracic Society. I used to be very heavily involved in these educational seminars years and years ago, and my time with the CTS previously, I really have great fond memories of. I know that this is somewhat of a mixed audience, so I tried to keep it, fairly broad. I think I'm going to be touching on things that almost all of us are going to find very common and things you already know. And there may be a few morsels here and there of things that are new or perhaps a different perspective. This talk is not heavy on physiology, although towards the end, when I talk about some of the mechanical ventilator issues and potential complications, I do cover that a little bit. But really, the point of this is to have a good Q&A. So I'm hoping that this portion of me presenting won't take too long, and really look forward to discussion and questions as well. So, and then in terms of disclosures, I should say that I do consult for some companies and industry. I also co-founded a company myself based on some of the research and intellectual property that's come out of my lab. Just to mention that offhand, it doesn't really impact any of the content of the current presentation. So I apologize for not including the disclosure slide. I just simply forgot. So let's see. Can you hear my voice okay, Jason? Just coming along?
Loud and clear, coming through great, and a verbal acknowledgement of any conflicts works for us.
Okay, good. So just to be a brief outline, I'll be talking about just asthma briefly. I think this crowd will be very familiar with it. I will mention and introduce this idea of critical asthma syndrome that our group has really, written about and thought about in terms of how we look at our patients. I have a couple of cases sprinkled throughout, talk a little bit about acute management of asthma in the inpatient setting. Briefly mention just one slide on asthma and COVID. There's been a lot of studies that have attempted to answer various relevant questions to that topic, and the guidelines have really just briefly touched upon it. and then talk a little bit about mechanical ventilator management, briefly on complications, and then Q&A. So, and I hope to try to answer all your questions. So we'll just start out with a case. This is one of our cases of a patient I took care of. 69-year-old man presents to the emergency department with several days of wheezing, dyspnea, dry cough, with minimal to no relief with nebulized bronchodilators. You can see the chest X-ray there to the right, relatively normal except for some possible subsegmental atelectasis in the right base of the lung. Patient was hemodynamically stable, afebrile, except for a little bit of tachycardia and tachypnea, and with visible use, mild but visible use of some accessory muscles. You can see the blood gas there, pH of 7.37, arterial CO2 44, and arterial oxygen partial pressure of 95 millimeters of mercury. So the question is, what is the most appropriate assessment of this patient's respiratory status, and what is the next step in management? A, this is an appropriate blood gas, just monitor. B, respiratory fatigue, begin non-invasive positive pressure ventilation. C, impending respiratory failure, begin non-invasive positive pressure ventilation with a low threshold to intubate if fails this non-invasive modality. And D, respiratory failure, proceed to intubation. So I'll just give you a minute, just a few seconds to look at this, think about it. And unless somebody wants to volunteer an answer, what you could do is just note what you would do, and we're going to come back to this case after a few slides. A little bit of some sobering statistics about this condition. I think most of us, if not all of us, already know this. Asthma is perhaps the most common respiratory disorder in the world, affecting the entire lifespan. Unfortunately, patients still die from asthma, and we've seen these patients, and you've seen them too. About 9 to 10 die in the US alone daily. In the US and globally, it's a much higher number. About 10% of asthmatics have severe asthma, which put them at much higher risk of deterioration, and the costs are only increasing. There was a publication that came out about 2-3 years ago where they looked at the cost of asthma over 2 decades, and it approaches almost $1 trillion, so about 908 billion. And if you have lifelong asthma, you really have a poor quality of life and very high morbidity, and it really does impact your life significantly, as well as threaten it for an unfortunate cohort of patients. So I think we're all familiar with what asthma is. It's a complex disorder, but basically mechanically what happens is you have airflow obstruction and reduced ventilation as a result of that. And this is just a cartoon that shows that the airways in cross-section. It's a complex multicellular and immune disorder, and that involves predominantly the airway smooth muscle cells, but also the epithelial cells and the immune system. This is in cross-section. You can see the normal airway to the left. You can see a nice normal epithelium, and the smooth muscle cell is nice and small. But here on the asthmatic side, you can see a lot of mucus-producing cells. The basement membrane is very thickened and a very bulky airway smooth muscle. Here you can see that in the pink H&E staining. And you can see how this pathology causes significant luminal narrowing to the airway. And this process is, of course, dynamic. It's not a fixed process. There's also significant mucus production. So you can see a large mucus exudate and plug right here with a goblet cell, a mucus producing cell metaplasia, and the epithelial layer here and here that's been magnified. And you can see the smooth muscle hypertrophy is really quite extensive. You can see all of this large bulk of a hypercontractile airway smooth muscle. And really this is the key pathology that results in the symptoms that patients present with. Asthma has evolved. We're sort of in a golden age of asthma. I won't spend a lot of time on this, but this is simply to get everyone on the same page in terms of how we really think about the clinical phenotypes of asthma, and then the molecular or cellular mechanism, which we call endotypes. And really, asthma is really looked at in terms of Th2 or Th2 high or Th2 low asthma, or eosinophilic and non-eosinophilic. And the great thing about looking at asthma this way is that we have now therapies, biologics that are really being directed towards the immune, cytokine, and cellular pathologies that exist in the disease. And we are seeing some significant responses with these biological therapies that I'm sure many of you have been using in clinic. Just a brief definition of severe asthma. Any asthmatic that's treated with a high dose inhaled steroid with and without a long-acting beta agonist in the previous year, or someone who uses systemic steroids for more than 50% of the previous year, really it falls into this category. Now, this is different from just those who are uncontrolled. Uncontrolled, maybe somebody who's just not compliant with their inhalers, and once they become compliant, then they're actually doing much better. Severe asthmatics really are a different beast, and many times they really have uncontrolled symptoms despite maximal therapy. They have frequent exacerbations, more than 2 or 3 oral corticosteroid bursts a year, and they have serious exacerbations with at least 1 hospitalization, ICU steroid mechanical ventilation in the previous year. And they do have evidence of airflow limitation on their FEV1. And another way of thinking about this is, if you have a patient who you're trying to taper off some of their medications and then they basically exacerbate during that process, or as you come down on inhaled corticosteroid, they require additional systemic corticosteroid, this patient also falls into the severe category. Now, our group has sort of looked at this from a slightly different perspective, and we've been frustrated with terms like, refractory asthma, status asthmaticus, brittle asthma, near fatal asthma. You see these terms being used clinically, and they're even used in various publications. Well, when we look at this and we look at what is this patient, we came up with the term critical asthma syndrome. And the idea here is that this is a spectrum of presentation, right? You have patients who have mild to moderate disease, you can manage them at home and they'll be fine. But then a cohort of those patients are unresponsive to therapy, and then they fall into this danger zone where they will kind of quickly deteriorate and either end up in the ED, intubated, or end up going straight to the ICU, right? And unfortunately, some of them will succumb to the condition. But the idea, as you can see here in the yellow boxes, is to identify unstable patients, right? Those who you thought were doing okay, but really aren't, and they quickly deteriorate. And the idea is to see who is unstable and who is severe, whether they're in the outpatient setting, in the emergency department, or obviously in the inpatient setting, and to be very aggressive and act on them as quickly as possible. So the idea is to have a high index of suspicion and very closely monitor these patients, and recognize that with this condition, or the critical asthma syndrome spectrum or scenario, patients can deteriorate very, very quickly. And we've even had patients who succumb at home, even before the ambulance can get there. So the idea is to be very aggressive and to try and identify these patients and recognize them early. And I think that's part of the quote unquote critical care management or understanding of this disorder. This is from the GINA this year's update guidelines in terms of risk factors for asthma-related death. I think this is a very important table to have in mind. Those patients who've had near fatal asthma, who've been intubated or had ICU stays in the past, that's a definite high risk factor. Those who've been hospitalized, have had a lot of emergency care visits, is a risk factor. Those who are currently using or have recently stopped systemic corticosteroids, that's a marker of severity, and they really have to be monitored carefully. Also, those who are not using their controller inhalers, that's a big one. Overuse of short-acting beta agonists is another big one. In fact, the beta-2 receptor agonists, the short-acting beta agonists, actually are pro-inflammatory. This is well known in the scientific realm, and recent evidence, clinical evidence, has come out showing that people who only use albuterol actually are increased risk for exacerbation versus those who will use intermittent dosing of inhaled corticosteroid. And that's something that has its own discussion and a debate. Those who have poor adherence to asthma action plans, or really don't, are poorly compliant with therapy, have increased risk, have more symptoms, and the 2 domains of risk for exacerbation and debilitation are increased significantly. Interestingly enough, those who have a lot of psychosocial stressors, that is a big risk factor. In fact, that's one of the things that triggers increased eosinophilia and active eosinophilic degranulation is psychosocial problems, mental illness, and stress. those who have food allergies, and of course, there's comorbidities that can make things worse: diabetes, cardiac disease. People who have frequent pneumonias, other things that will increase the risk of exacerbation, GERD, aspiration, things of that nature. This is sort of an old idea, an old table. This is stuff we teach our trainees, and it's something that is commonly misunderstood, and it's not worth spending a lot of time on it, other than the fact that when patients don't look hot and they have a quote unquote normal looking ABG, that's in fact a bad sign. And really, these patients should not be hypoxemic. And if they are hypoxemic, then it's almost too late, in the sense that they really should be on non-invasive ventilation, or they should be intubated, because that's really the last step before you fall off the cliff. But things begin where you have a little bit of respiratory alkalemia, and then the CO2 starts to rise from 28 to 30 to 38. And then once the CO2 starts to rise above 40 and your pH begins to drop even slightly, this is where you really are in the danger zone, in this red box here, and you really have to consider additional mechanical support to offload the work of breathing. So we're going back to this first case that I mentioned. You can look at it again to remind you. But if you just look at what the slide previous to this indicated, and looking at that blood gas and then how the patient actually looks, and look at the various options, you can see that the best option is clearly C. But you can also make an argument for D, and that really depends in terms of your clinical judgment. So a little bit about therapies. The old paradigm in asthma is one size fits all, and this is something that no longer stands. Patients were sort of brought in with a sort of a cookie cutter approach: step up, step down, get on your controller. Treatments, oral corticosteroids, leukotriene muscarinic antagonists, and other third and fourth line agents have been used. The one exception is Mepolizumab, which has been around for a while now. Believe it or not, some of you may have experienced this or not. We've even used immunosuppressants in the past historically. Some experts, asthmatologists, have in very, very sick patients before the age of biologics have looked at those kinds of treatments, despite the lack of supportive evidence. And really, this one size fits all there's a huge lack and a gap between what you can offer the patient and how they're doing, and what the guidelines at that time had suggested. And now this has really evolved, especially in the new area, in terms of how we think about asthma, and we were able to clinically phenotype these patients, as well as endotype them in the omics age. And as I mentioned earlier, having type 1 or type 2 high and low, we're able to think about these patients more from their cellular and immune phenotype, and thus ushering in the age of biologics. And I'll get to some of the biologics a little bit later in the critical care setting, which there's some interesting data on. Just a little bit of an aside in terms of COVID-19 and asthma. Some of you, I'm sure, have your own opinions on this and your own experiences. But during the pandemic, it was very interesting what happened with asthma, is that many countries actually saw a reduction in asthma exacerbations of flu-like illness, probably because of all the social distancing and masking. But patients with asthma, the data did not suggest that an increased risk of getting COVID, although there is some of that literature is mixed. Those with asthma who were well controlled did not have an increased risk of COVID-19 related deaths, specifically on deaths. However, risk of COVID-19 was increased in those who recently needed steroids, which is really a indicator that they're not well controlled, meaning oral corticosteroids such as prednisone, and in those who were already hospitalized with severe asthma. So that was the exception to the rule. And really, the goal in patients in the COVID pandemic is really, you got to maintain good control, take your inhaled corticosteroids, use biologics where needed, try to reduce the risk of exacerbations, and minimize the needs for oral corticosteroids as much as possible. This is a slide that I don't have to spend much time on, but the basic six or seven things you want to do is obviously bring these patients in under close monitoring, give them some supplemental oxygen, even if they're not hypoxemic, aggressive use of bronchodilators, SABAs and SAMAs, Corticosteroids, of course, intravenous magnesium is very, very useful and potent. It's a bronchodilator. And there's now emerging literature to suggest that biologics may be useful in some select patients in the acute setting as well. We also often will give some IV hydration to these patients to minimize, drying of the airway mucus and really keep them in a hydrated state. And of course, mechanical ventilatory support when needed. We've also used terbutaline and other stress hormones that these can be given in various different routes. This is one way of giving it subcutaneous. So there is some interesting case reports on the use of Benralizumab for near fatal asthma. I don't know if any of you have encountered this literature. There's a case report from Spain, 23-year-old man, active smoker, who was poorly adherent to his inhaler controller medications with intermittent marijuana and cocaine use, came in with hypercapnic failure, was intubated in the ICU, and was discovered to have a fairly high eosinophil count of 600 cells per microliter. Patient continued to do poorly despite the standard status asthmaticus therapy, beta agonist steroids, magnesium, etc. The treating physicians decided to give the patient a single subcutaneous injection of Benralizumab on day 4 of the hospital stay. And then by day 8, there was a significant improvement in the respiratory status. There was normalization of the pH and the CO2, a decrease in the peak expiratory pressure and the airway resistance on the ventilator. And then on day 13, the patient was extubated, sent out on a prednisone taper, discharged home. Here's another paper where they do a little bit more careful reporting of what happened with the patient. You can see here in the top panel, this is the peripheral absolute eosinophil blood count, quite high in the 800 to 900 range. And the patient received Benralizumab with a very precipitous drop in the peripheral blood eosinophil counts, and the peak expiratory flow rates correlated with that treatment, and there was a significant increase in that from about 200 to about 500. And then on the y-axis here on the right panel, you see the improvement in the patient symptoms relative to when the Benralizumab injection was given. And then here you can see the percent improvement in symptoms, including cough, dyspnea, and wheezing. And then the purple line is where hospital discharge was. There's an interesting quote from the patient. I don't know if you can see that at the bottom there. Patient stated, "I felt better within 12 hours of the injection and was walking around the hospital within 24 hours." That's an interesting anecdote. This is not the first time I've heard or seen this, both in my anecdotal experience as well as in some reports in the literature as well. I'd be curious to hear what you guys have experienced. There's another case report looking at Mepolizumab for near fatal asthma. There's a similar story here without going too much into the detail. This patient was on a prednisone taper. There's a relative reduction in the percent eosinophils, and then when Mepolizumab was given, there's a further decrease. And then on the right panel, this is a patient who was on a ventilator. You can see that when the Mepolizumab was given, there was right after a period of prednisolone use, there was a reduction in the CO2, meaning ventilation was improving, with a corollary reduction in the peak inspiratory pressure as well, which suggests there was decreased airway resistance, more bronchodilation, maybe less mucus production, etc. So just changing gears a little bit, I mean, that's sort of on the therapeutics, side, whether it's pharmacological or biologics. People often ask about, what about the use of high flow nasal cannula oxygen in critical asthma syndrome? This has really not been studied, to my awareness, in adults with status asthmaticus or directly compared in head-to-head studies with non-invasive ventilation. There is one retrospective observational study that showed the high flow tube may benefit children with status asthmaticus and lead to lower intubation rates, but that's not really been validated. There's anecdotal evidence from our experience at UC Davis that suggests that some subset of patients with critical asthma syndrome could potentially benefit. During the COVID pandemic, we had those where we felt they had near fatal asthma and COVID, and we were able to avoid intubation in those patients. But again, the context here is within COVID, so it's not a clean sort of anecdotal experience. And this was, of course, with additional standard therapies for both conditions, the asthma and the COVID side. So really, we really can't make a firm, and the literature doesn't have sort of a firm final recommendation on this. Something similar can actually be said of a non-invasive mechanical ventilation, although there are just a handful more studies on this. This is also covered in the GINA 2022 guidelines. I mean, from a mechanical load and physiological standpoint, you can see how non-invasive ventilation in acute asthma can be helpful. If you put your attention to that red box there, you can see how it reduces the work of breathing by reducing intrinsic peak and the resistive load. It helps with maintaining open airways and a larger airway diameter, which is correlated with less bronchospasm. It helps with collateral ventilation and ventilation perfusion matching and improvement in your blood gases, and less use of accessory muscles. But in terms of the literature, the evidence is actually quite weak. There's no significant difference in the rates of intubation. This is done in 2 or 3 studies, so not that many studies, and the population sizes are quite small. But if you do use non-invasive mechanical ventilation, which we do in cases where it's appropriate, you really got to monitor these patients very, very, very carefully, very closely, which I'm sure many of you have experience with that modality. In terms of Heliox, I don't know if this is widely available, but it's something that is available in I think most large medical centers. It's a mixture of oxygen and helium. And the idea here is that you make the air less dense and you increase what's called its kinematic viscosity. And what this does is it leads to more laminar airflow and less turbulent airflow. And as a result, in doing that, you're actually able to deliver ventilation at lower resistance. It doesn't have any effect on bronchoconstriction directly per se or inflammation, but it does in asthma decrease the intrinsic peak by about 4 to 8 centimeters of water pressure, which is quite significant when it does work. There are other indications like croup, stridor, laryngeal masses, asthma exacerbations being one of them. The one thing to be cautious about is that in those asthmatics with mucus plugging and severe VQ mismatching from hyperventilation, Heliox should only be used if the O2 demands can be met. And that's because of the ratio of the oxygen to the helium you can see right here is such that the oxygen component is on the lower side. This is a case of near fatal asthma. The X-ray there is on the right. You can see the patient's intubated there. 33-year-old woman presented with critical asthma syndrome that rapidly progressed to acute respiratory failure. Patient failed BiPAP treatment, was emergently intubated. And you can see the severe hyperinflation, flattening of the diaphragms, vertical heart with about 11 ribs showing, and indicating that this this patient really has a large, big chest with a lot of air trapping, and this is a patient that is exquisitely difficult to ventilate on the mechanical ventilator. This is a bit of a busy slide, but just try to highlight some of the key points. The box you see there on the right, that's light blue, really talks about some of the preferred ventilator settings. We don't have to go through that in great detail. Other than that, it's important to recognize that these patients really should have a relatively low respiratory rate to try and avoid the air trapping that can happen and allow enough time for exhalation prior to the initiation of the next breath. And really, after these patients are intubated, their mechanical ventilator settings really have to be personalized to their needs, with keeping lung protection in mind, meaning that you're using PEEPs only high enough to match their intrinsic or auto PEEP, using volumes that are, again, on the low side, because these patients are vulnerable to barotrauma, polytrauma, and even biotrauma. And biotrauma is an interesting one. It's an idea that's quite old, but only recently has been gaining attention, in that when you have massive stretch or high pressures or over distension, the alveolar epithelial cells themselves, just that shearing pressure alone will cause production of cytokines. and will just cause an acute inflammatory state directly. And really the tidal volume and the PEEP, the extrinsic PEEP and the plateau pressures really all have to be targeted and individualized for that patient. But the general idea is you want plenty of time for exhalation. You can tolerate some high peak pressures, but you want to maintain a reasonably low plateau pressures to not cause further injury. These patients are typically not hypoxemic, so you want to rapidly wean down the FiO2 from 100 down to just whatever is necessary, and give them at least a 1 to 3 I to E ratio in terms of their expiratory time. And I can elaborate on this further. Be happy to have a discussion with your experiences as well. Sedation is really important in these patients. We're often using anesthetic grade sedatives such as ketamine, propofol. Of course, the standard benzodiazepine and opiates are also used. But if you're noticing these patients, despite everything, their pH is dropping, their CO2 is climbing, over the ensuing hours, and you're doing permissive hypercapnia, you're doing lung protective ventilation, you're still having problems, this is a time to consider using paralytics or neuromuscular blocking agents on these patients. There's some additional information on that slide that didn't come out, but this is something we often do to try and really maintain full control of the work of breathing and synchronization with the mechanical ventilator. When all else fails, of course, you have the anesthetic algorithm. There's been several papers on this, looking at not just the intravenous anesthetics that I mentioned right here on the left side, but also the inhaled anesthetics such as isoflurane and others, sevoflurane. And there's some studies and some controversies regarding the various fluorines as well, and that's a little bit outside our circle of discussion here. But if you do have to gas the patient, this really requires very specialized consultation with an anesthesiologist and the use of specialized equipment. It's something I've only had to do once years ago. Luckily, this is not a common problem, but this is something just to be aware of in terms of critical care management of asthma and really other obstructive airway disorders, but in particular asthma. Extracorporeal membrane oxygenation, or ECLS, and also extracorporeal CO2 removal is a very sort of interesting and emerging therapy. I know we were doing clinical trials at UC Davis. I don't know where the extracorporeal CO2 removal sort of approvals or studies are these days. If anybody knows in the audience, be glad to discuss that. But the indications are for those who have refractory acidemia, who have sort of a declining clinical trajectory and inability to provide lung protective mechanical ventilation. It's less invasive than ECMO. You can see here, this is really just, it's a device, and you have to be able to access the vascular space. And the idea is to remove the high CO2, which is resulting in respiratory acidemia. And it removes it much more efficiently than it can deliver O2. And some of you may know more about this than me, because it's not something I've actually used, but I'm aware of it. I'm not aware of any large clinical trials, but there are some case series. And there may be a role for this in less severe asthmatics, but I would say not in those who are super sick, who are barely holding their own on the ventilator. So it's, I think, for a certain population. Briefly on talking a little bit about complications, the obstructive airway diseases really are at risk for hypotension and significant barotrauma, the development of pneumothoraces, dysynchrony with the mechanical ventilation, and of course, worsening bronchospasm as well. This is something we commonly see, especially getting patients who have been down in the ED for hours, is getting a type B lactic acidosis. And this is actually an important one, because if they're on continuous nebulized beta-2 agonists, they get a type B lactic acidosis, which further increases their work of breathing, because now they're working harder to blow off all that extra CO2, because now they have a separate acidosis, a metabolic acidosis, that's contributing to the problem. So this is something I always keep an eye on and try to mitigate or minimize as soon as possible. In terms of near fatal asthma in cases with mucus plugging. Now, this can be exquisitely difficult to deal with. Most cases of fatal asthma have extensive mucus plugging in the airway with a quote unquote normal looking x-ray or an x-ray that has some hyperinflation. Here you can see on this CAT scan with the red arrows, you can see the blood vessels are there in the white, and you can see mucus plugging here on the right adjacent to that. This was a 7-year-old woman with really mild to moderate asthma and some allergic rhinosinusitis, had 3 days of shortness of breath and wheezing, presented with worsening hypoxemia, actually. And you can imagine why, right? You got a bunch of mucus plugs, you have a lot of airway shunt physiology, and patient has some hyperinflation. You can see on the CT the mucus plugging. Now, this patient it was an interesting case because she was successfully treated with bronchoscopic aspiration of these central mucus plugs. And further evaluation showed this patient was hypersensitive to Aspergillus fumigatus with a serum IgE of nearly 1800. But if these patients, deteriorate, if they're intubated, then, you have access to the airway. But if they're not, it can be quite tenuous to deal with. A little bit about air trapping and auto peeping or intrinsic peeping. All of you will notice on the mechanical ventilator on the flow time curve that during the exhalation phase, if you don't quite return back down to 0 here, you can see in the morphology that you get a breath before you fully completed exhalation. So this dotted line is a complete exhalation. There's an incomplete exhalation, and then you get a breath. And this is how sort of the breath stacking phenomenon occurs. And this goes back to the earlier point that you got to have a slow enough respiratory rate that patients are able to have that extra E time in order to exhale. So this patient's trajectory would be something like this. If you can see my cursor, they would need about this much additional E time before they fully exhale, if they ever do. And when this doesn't happen, all of this, intrinsic or auto PEEP causes dynamic hyperinflation and retention of air constipation, and adding that extrinsic additional PEEP to try and match this intrinsic PEEP is something that helps. There's other things that can be done, such as playing with the flow time waveform and other tricks that we have up our sleeves. But this is sort of just the basic idea. And the idea here is that it's not this dramatic, but when you have severe breath stacking, your FRC prime basically is just going up and up and up. And so you're inflating the lung and you really don't have time even for the next breath. And often with these patients, what we have to do is just disconnect them from the mechanical ventilator and just let them exhale. And we sometimes even have to push on both sides of the chest just to help get that extra air out. Here's another clue on the volume pressure, excuse me, on the volume pressure hysteresis curve. You can see that if they have this kind of morphology, that little red area, this is called bird's beaking, and this is also a marker of hyperinflation, air trapping, auto PEEP. Now, what this does mechanically is it makes the work of breathing much more difficult. Patients will have they'll be at risk for lung injury from excessive tidal volumes, and this also impacts their hemodynamics negatively. So this can be a real problem to deal with. Now, the solution in part can be the application of extrinsic PEEP, meaning the PEEP that you control on the mechanical ventilator. What's in orange is the airway pressure. The transpulmonary pressure is really the alveolar pressure minus the intrapleural pressure. And what you can see here that in a normal case, the transpulmonary pressure, this is a normal healthy patient, is about -2. When you have hyperinflation here in panel B and you have high intrinsic PEEP, you can see that the work is increased. The transpulmonary pressure is much higher. The work of breathing is simply the product of the pressure times the volume. So you can see this is now a 5-fold increase in the transpulmonary pressure, meaning the workload that the patient has to do is going to be way higher for any given volume that they have to move or ventilate per unit breath. And when you apply, you can see here, this has gone from 0, 0, now 8. This is the applied extrinsic PEEP. It's gone from 0 to 8. You can see this is simply the difference between the two. And now their transpulmonary pressure is closer to 3, which is closer to a normal healthy patient, right? And this does translate into the work of breathing that the patient has to do, or even the work that the ventilator has to do, which implicates mechanical ventilator synchrony or dysynchrony. Here is sort of another way of looking at it. And when you address this problem, some of these things I already covered in the first bullet point here, in terms of bagging the patient, removing them off the ventilator, using bronchodilators. Now, the ventilator adjustments really should be geared towards what you see in the bottom here, right? You want an appropriate amount of ventilation with a reduced respiratory rate, a little bit shorter I time, and then a extrinsic PEEP that matches their or is 1 to 2 points below their total auto PEEP or intrinsic PEEP. So I think, in summary, I don't have to read all those bullet points. This is really a spectrum disease, and patients have to be recognized early. They have to be brought in and observed very carefully, and you have to act quickly, not let them get to the point where they're just crashing and burning. It's better to intubate them a little earlier than later, of course. So early recognition is key. The mainstay therapies, I'm sure you're all aware of, the beta agonist, steroids, IV magnesium, but you can also consider using leukotriene receptor antagonists, biologics, as I showed you some of the data. Non-invasive mechanical ventilation can be used, but really there's not great literature on it. You just have to observe them and electively intubate. And really a very careful and cautious use of mechanical ventilators in terms of monitoring the patient and avoiding breath stacking, and because if they pop a pneumo, they get a quick, development of tension pneumothorax and PA cardiac arrest, which none of us want to see. So I think that's the end. Happy to answer questions. Just covered the main highlights, but I think we have time for a few questions. Excuse me.
Thank you so much, Dr. Zeki, for a fantastic presentation. And I know you also took out numerous slides to fit into the time requirements we've had. So thank you so much. And yes, we've now got hopefully at least 15 minutes available for Q&A. We've got a few questions that are loaded up from the presentation. If anyone else would like to ask a question, please go ahead and type it into the Q&A panel and we'll do our best to get to everything. So let's get started. The first question, which you and I saw at the beginning of the presentation, is just simply a question to know, does your team at UC Davis have an asthma protocol to share?
Not quite sure what Pablo means by asthma protocol. We do have the Road Center, which takes care of, the Road program, which takes care of COPD and asthma patients in terms of education and using their inhalers and things like that. But I think maybe, I don't know if Pablo has access to audio or can clarify the question, but if you're talking about in terms of asthma protocol, what we do in the inpatient setting, what we do in the ICU, I'm not aware of one. The hospital has, certain policies. We've certainly published in book chapters and in papers sort of, what to do in terms of hospital medicine management of asthma, and also asthmatics will end up in the intensive care. But I have not seen a specific protocol that we, for example, use in the ICU in terms of these are the 20 things you want to do or not do for the treatment of asthma. It's really an art informed by the best literature that we can get our hands on. Oh, I see Dr. Kuhn is also in the audience. Fantastic, and maybe he can give his perspective since we both work together. But I think that's probably the best answer I can give you, Pablo. I'm sorry if that's not satisfactory, or maybe you can clarify your question further.
Great, thank you. Yes, Pablo, feel free to try to clarify your question via the text input. And if need be, we can always enable your audio and we can try to take it from that approach. Next question, pretty simple one. And this one is, will the audience have access to the slides afterwards?
Yeah, I mean, if you want, I can share the slides, no problem.
Okay, great. If you'd like to be able to get in touch with Dr. Zeki and you don't know how, feel free to contact the California Thoracic Society, info@calthoracic.org, and we'll help facilitate getting you a copy of the slides. All right, next question. Speaking of Dr. Kuhn, great talk, Dr. Zeki, he says. Now that ECLS is increasingly used in adult populations, do you still see a role for inhaled anesthetics in near fatal asthma?
Yeah, that's a really great question. I think, Brooks, it's a case by case basis. I mean, there may be a scenario where, if ECLS, if it's, there's contraindications, there's reasons you really can't use it, or risks, then certainly you have to go for some of these alternative, like the gas option, inhaled anesthetics. But yeah, I mean, and of course, there's no head-to-head trials, but ECLS is a great modality. It's gotten better, and people are gaining more and more comfort with it. I know certainly we have a program at our institution that's really been growing. So, the answer is yes, ECLS is a go-to, but I think it's really going to depend on case by case basis and what the patient really needs. And then there's also, of course, the larger national trends. What are other people doing? What are other institutions doing, and what's really working well for them? And the more data we can get that tells us what's the safest and best approach, I think is the way to go. But yeah, I mean, we reach for ECLS first, and like I said, inhaled gas is not used that often. And in 20 years for me, I've done it once maybe, that I can remember, and other cases that I've considered but didn't end up using it. So I hope that answered your question.
Thank you. Next question. I think I can turn this into the question. Do you advocate venous BG versus ABG?
Oh, yeah. This is a question that always sort of causes a little bit of a contention. I'm a huge fan of arterial blood gases for many, many reasons. I just think they're more accurate, they're more informative. You can address the oxygen issue, AA gradients, as well as, of course, CO2 and pH. But venous blood gases are also useful for looking at trends, and maybe in situations where the diagnostic aspect of the ABG is not necessary, and you're really just looking for trends in the CO2 and trends in the pH. So I think there's a role for both. But I think in the initial stages when you're really making assessments, ABGs are preferred. But sometimes you can't get an ABG, right? Patients are writhing around, and it's safer to get a VBG, but you have to be careful because a VBG may not be that accurate. There's regional perfusion issues, and it's not the same as an arterial blood gas. So you really have to use your clinical judgment.
Great, thank you very much. And there we see a thank you from Pablo. So I think you did a good job,
Pablo,
getting that answer. Next question. First, the thank you for your presentation, and the question: in your experience, what are the risk factors for mild asthma CAS?
Well, that's a good question. I mean, mild asthma is typically not the spectrum of disease where we see it sort of all of a sudden present with a critical asthma syndrome and deterioration. Certainly, mild asthmatics can develop severe asthma over time. But the critical asthma syndrome, if you go back to, I think, some of the earlier slides I have, there is a risk profile. And I mentioned some of those things in terms of risk profile for those who have increased risk and those who actually have increased risk for exacerbation. Then there's another profile for those who have increased risk of asthma-related deaths. But if you have a patient that is increasingly becoming symptomatic and requiring higher and higher dose of inhaled corticosteroids, or they're requiring prednisone, you're now in the severe asthma sort of land, right? And remember that you have to be very careful to say that's a true severe asthmatic, because there are those who are simply uncontrolled because they're just not taking their medications like you think they are. So you really have to make a careful assessment. But typically, you don't have a mild asthmatic that's going to develop, status asthmaticus, right? That isn't usually the case. I may be biased in part because, I co-direct the severe asthma clinic, and we see sort of the severest of the severest cases. But certainly, having said that, it doesn't preclude the fact that some mild asthmatics can certainly get acutely very, very sick and end up in the ED or in the ICU. That certainly can happen. But one of the predictors and harbingers of that is their ACT score dropping by 3 points or more? Are they using albuterol more than 2 to 3 times a week, and that's increasing. If they're using it daily, they may not be mild anymore, right? So the idea of mild or mild intermittent is that, they're just using a low dose inhaled corticosteroid, or the equivalent, which would be just a Zeferlocast or Montelukast leukotriene receptor antagonist, which is an ICS equivalent. But if they're beyond that, if they're requiring higher doses, the addition of a LAMA and or LABA-LAMA, then you're really outside of just mild asthma. Now you're entering into the more moderate asthma range. The next question.
Oh, there we go. Sorry about that. I was on mute. Next question. First, another thank you. And the question, I believe adding applied PEEP decreases the threshold load, but doesn't one need to be careful in monitoring the plateau pressure to reduce lung stress?
Yeah, so the plateau pressure is really a surrogate for the alveolar pressure. And when you talk about plateau pressure, you're really talking about transpulmonary pressure, which gets back to some of those earlier slides I showed where when you apply it, you were talking about, where we showed the 3 lungs and the application of PEEP. When you, by increasing or decreasing PEEP, right, you are changing sort of where you're starting. So the overall pressure is, changing. But the bottom line is that the plateau pressure, because it represents the alveolar pressure, is a surrogate for the transpulmonary pressure once you assume that the pleural pressure is stable. So most patients, in our calculations, we assume it's about -5 centimeters of water, which accounts for the chest wall. Okay, it's about -4 to -5. So to really understand this issue, you have to consider 2 things. You cannot get away without applying PEEP. You need to apply the PEEP in order to reduce the workload or the work of breathing. But while you're doing that, you also have to monitor plateau pressure, try to keep it less than 30, because if you overstretch the lung vis-a-vis a high transpulmonary pressure, also known as lung stretch, you're going to undo any benefit that you're gaining by causing volume trauma and barotrauma. So that may not have been a very complete or clear answer, because you're really talking about 2 separate things. So if that wasn't clear, please let me know. But I would answer that by saying you got to give the appropriate PEEP, but at the same time, you got to keep the plateau pressure, as close to 30 or less as possible, right?
Thank you. Let's see, a question, or I'm not sure, this might be a comment from Georgia. Again, please send the email to request slides. I think you're asking me to repeat the email in order to request them. I'll go ahead and post it to the chat right now. And again, you can email info@calthoracic.org to request the slides. We'll help facilitate that. Follow-up question here from Dr. Kuhn. Thanks for the answer. Can you speak to airway clearance in very severe asthmatics intubated, sedated, and NM blockaded? I'm concerned suctioning and suck out bronchs lead to more airway trauma and potentially bronchospasm. But then again, NM blockade leads to decreased clearance and plugging.
That's a great question, Brooks. Again, really case by case. I mean, I've had patients who were just about to be intubated, like that case I showed, just about to be intubated. They're hypoxemic and they're awake, and I'm talking to them. I will intubate them and suck out a bunch of cats, and all of a sudden they're doing fine, right? And that's a patient that has maybe not a severe exacerbation, but enough that they're wheezing, they're on bronchodilator steroids, and then they just have a lot of mucus plugging that's giving them a shunt. A patient who's intubated, sedated, on neuromuscular blockade, those patients can also deteriorate, right? And even if you're doing everything right, if their airways start closing off because of bronchospasm, you're basically stuck, right? So the decision, in my opinion, to try and suck out some of the mucus plugs really depends on assuming the worst case scenario and making a decision. Do they have enough give, right? Do they have enough physiological reserve that if that were to happen, I'll be okay, Meaning, is what I'm gaining from suctioning out the mucus plugs acceptable with the attendant risk that could happen? Now, how many times have I actually done those bronchs in patients that sick? I can't remember the last time I did that. Because I have to be really convinced that they have extensive plugs. And the other problem is a lot of those plugs are not proximal airways. They're distal peripheral airways. And in fact, I took out, I think, something like 6 slides that are just talk about that, which is the mucus plugging phenomenon and how that changes, the airways and where they are in the airways. I removed all those slides just in the interest of time, but, I would be very careful not to do that unless I felt like what I was gaining was worth the risk, Brooks.
Thank you. Just a few more here. So,
hey, Heidi.
Here's a colleague.
Heidi,
Yes. A question from Heidi, a comment regarding the anesthetics and ECMO. In PEDS ICU, we definitely use inhaled anesthetics in near fatal asthma. Problems usually surround vasodilation and hypotension. So USU needs vasoactives with care for risk of arrhythmia, given the other asthma meds. Also have used ECMO. They do well, given the reversibility of this disease. Encourage bronch once on ECMO to get those bronchiocasts out. Really enjoyed your talk.
Oh, thanks, Flora. I agree with everything that you said. And it kind of dovetails with what Brooks' question was, which is if they're on ECMO, you want to protect the lungs. Obviously, you want to kind of rest the lungs, but we do bronchs on those patients. We suck out plugs. If they got purulent pneumonia, those things can all cause sepsis and other problems. So yeah, I agree with everything that you said there, and it's really good to hear from you, and I guess see you digitally, Heidi. It's been a few years.
I love it. Reunions on Zoom. You have another new part of our new society. All right, we got the final question here. It's a follow-up, another question from Pablo. Does your team use the ROX index on HFNC? Also, the VC mode, does your team check the PP-LAT Q4 to check the resistance changes? Yeah. Mm-hmm. And has your department done research on mechanical power?
That's actually a question that probably Brooks can. So you guys probably all know, Brooks has he is a co-director of the COPD clinic, but also does mechanical ventilator waveform research, in terms of obstructive airways disease. So the mechanical power is a very interesting one. I don't know if Brooks or Jason Adams at our institute is actually looking at the mechanical power aspect in terms of the research, but maybe Brooks can chime in on that. But yeah, absolutely. In terms of the plateau pressure, yeah, I mean, at least by ARDS, it should be every 4 hours. And in very critical patients, if I have somebody who's intubated, who's on all these medications, including anesthetics, and is on neuromuscular blocking agents, absolutely, we want to keep a close eye on the plateaus. So I see Brooks there. Hey, Brooks, you want to chime in on the mechanical power question?
Brooks, you're welcome to unmute. And if you'd like to, I know we're putting you on the spot, but if you would like to unmute. We'll see. We're not sure if Brooks in a place where he can speak.
Yeah, but I can certainly, Pablo, can certainly get back to you about that as well. Find out for sure.
Great, thank you. All right, well, thank you so much, Dr. Zeki. Sometimes things just work out perfectly, and here we are at 6:01 p.m. Great job with a really fantastic presentation, and even better, I know how much our audience really appreciates the Q&A and just really giving all of your time. So thank you so much for supporting CTS and providing a great presentation. Thank you again to Electromed, maker of SmartVest, for just helping support this presentation to make these educational opportunities possible. These are really special opportunities, and we appreciate the support. Hope everyone has a safe weekend and enjoys the cooling weather patterns that are close. Have a great weekend, be safe, and we hope to see you a few Fridays from now at our next educational webinar. Thank you again, Dr. Zeki.
Thank you so much for the opportunity, and I wish everybody a great weekend. So, thanks.